My name is David Metz, and I'll be discussing NET symptoms and medical management. So in terms of NET symptoms, the most important point to think about is that patients with hormonal syndromes, in other words, functional neuroendocrine tumors, may potentially present earlier than patients who don't have functional syndromes. The functional syndromes are relatively rare, and that's why anybody with a neuroendocrine tumor knows that the mascot for the diseases are zebras. Other far more common diseases predominate, and that is the problem in terms of diagnosis, because for any physician in the field, if you have a hammer, it's always going to look like a nail. The presentation of functional hormonal syndromes varies significantly according to the type of syndrome that we're talking about. So what ends up happening is that the physician is looking for a needle in a haystack. So accurate diagnosis of a hormonal syndrome requires an astute physician who can put two and two together. And this is particularly important because early diagnosis has prognostic implications, because surgery is the only curative treatment modality, and in order to get patients early enough, you want to catch them before their primary tumor has metastasized to lymph nodes and then to metastases. And if you look at this triangle on the right, this upside down pyramid, neuroendocrine tumors specifically have a small primary with larger conglomerates of lymph nodes and significant tumor bulk in the liver. And in fact, liver disease or liver tumor bulk becomes a major determinant of ultimate outcome. So that it is important to try and find these tumors early when they are small and before they metastasize. And as I suggested, that requires an astute, clever, aware physician. In fact, the mean time to diagnosis for functional neuroendocrine tumors and for all neuroendocrine tumors is about 5 to 7 years. And if you can catch the patients earlier, you're obviously going to have a better outcome. Now, what is a functional neuroendocrine tumor? As you can see on this slide, functionality requires a syndrome. It requires a collection of symptoms followed by a biochemical confirmation. In other words, production of a product by the tumor leads to a symptom complex, and you can take a piece of tissue from a neuroendocrine tumor and stain it for various products, but if those products are not released, you won't develop the functional syndrome. So functionality is determining the presence of an excessive amount of a product that the tumor is producing. Although rare, there are 5 commoner functional neuroendocrine tumor syndromes, and those are listed in this slide. The carcinoid syndrome at the top by itself, because it predominantly occurs in the small bowel, although they can occur elsewhere. The next 4 syndromes, the insulinoma syndrome, Zollinger-Ellison syndrome or gastronoma syndrome, the glucagonoma syndrome, which is an excess of glucagon, and the vipoma syndrome or an excess of VIP, are classically pancreatic neuroendocrine tumors, and that's sort of the hedge that's sitting below the stomach in the diagram on the right. There are many other functional tumor syndromes that we're not going to have time to talk about today. At the bottom of this list are the PPomas. Those are tumors that produce pancreatic polypeptide. They're the most common of all the neuroendocrine tumors in the pancreas. However, PP doesn't cause symptoms. So even though it produces the product, it's really a non-functional syndrome. So we are going to go through these syndromes now and then talk a little bit about diagnosis and management. The carcinoid syndrome. This is the most common of all. In fact, it's twice as common as the next most common syndrome, and it has 4 classic symptoms: flushing, diarrhea, heart valve lesions, and cramping abdominal pain. There are a number of other rarer symptoms that are suggestive, but most of these patients have flushing and diarrhea. And you can see immediately how it's possible to misdiagnose patients because flushing can be attributed to other causes, for example, menopause. Diarrhea can be attributed to other causes such as irritable bowel syndrome, and therefore it takes 5 to 7 years to diagnose these diseases. Heart valve lesions are actually far less common nowadays because patients are being diagnosed more commonly. But anybody who has flushing and diarrhea together, one needs to think about the carcinoid syndrome. As I've already alluded to, this may be difficult to do. And this table over here, which is adapted from the Net Alliance monograph we produced many years ago, shows 3 very common causes of diarrhea and potentially flushing on the right side compared to the carcinoid syndrome on the left side. And the carcinoid syndrome has specific pattern of its presentation with diarrhea. The stool is generally watery. It does occur at night. It's uncommonly associated with bleeding, which can occur with inflammatory bowel disease, either ulcerative colitis or Crohn's disease. Constipation is not at all a feature of this, whereas irritable bowel syndrome on the extreme right of your slide commonly has constipation alternating with episodes of diarrhea. All of these symptoms can cause abdominal pain, but the abdominal pain when it occurs in carcinoid syndrome is an obstructive type pain, which is cramping and colicky and comes and goes depending on the position of the bowel. Carcinoids do cause fibrosis in the response around the lymph nodes that lead to this intermittent blocking sensation. One of the distinguishing features for irritable bowel syndrome, which is extremely common, is that that pain is relieved by defecation. And that is not really a typical syndrome that one sees in the carcinoid syndrome. So to diagnose the carcinoid syndrome, there are some standardized tests. The problem, there are false positives, and we need to always be aware of those. Because the tumor produces serotonin, which leads to the flushing and other substances that cause the diarrhea, the best test is the breakdown product of serotonin in the urine, and that's a 24-hour urine test. Many patients don't like lugging the jug, and so people have now started measuring plasma 5-HIAA, and that has been validated, although it's not always approved by insurance because it's expensive. You can also measure the product that's upstream from the 5-HIAA, the so-called serotonin product, which is a major cause of the symptoms, especially the flushing, and that is now being validated as well. Many of you have heard about non-specific markers of neuroendocrine tumors because all neuroendocrine tumors produce products, the most common of these being chromogranin A. Unfortunately, chromogranin A is not at all specific, and if you look at the bottom of the slide, there are many other causes of high chromogranin A's, whether you have a neuroendocrine tumor or not. Especially important, there are proton pump inhibitor therapies. In addition, low-level elevations of 5-HIAA need to be considered, and dietary substances that result in a lot of tyramine in the ingestate leads to elevated 5-HIAA, such as walnuts, avocados, bananas, butternuts, kiwi fruits. And in fact, some medicines, especially notable is Tylenol, can give a low-level elevation of 5-HIAA. So you have to have the symptoms together with an elevated product to make the diagnosis. Let's move on to the insulinoma syndrome. The insulinoma syndrome is about half as common as the carcinoid syndrome. It was initially called a beta cell tumor because it was developed from the islet cells in the pancreas and noted to be coming out of beta cells, which secrete insulin. So this is an excess of insulin causing the syndrome. It's the most common functional neuroendocrine tumor in the pancreas. It differs from the others in that it is often a benign tumor, although the hormonal syndrome can be very severe, requiring surgery in many cases. Often insulinomas are isolated and solitary and therefore easily removed when found, except in the hereditary form of the condition called multiple endocrine neoplasia type 1, which we'll touch on in a little bit. Almost all insulinomas occur in the pancreas, so your surgeon needs to know that that is a place to go and look and not other places. The classical features of carcinoid of insulinoma syndrome is Whipple's triad, which is an episode of low sugar hypoglycemia as a result of excess of insulin that leads to a low level of glucose in the blood that the patient then learns to respond to by eating sugar, and then the symptoms will go away. So that these symptoms typically occur during periods of relative substrate deficiency. And what that means is when you're exercising or fasting, the tissues that depend on glucose, namely the central nervous system, get short of energy supply and symptoms develop. And in fact, patients learn to do this. So unexpectedly, many patients with insulinoma syndrome actually end up presenting with obesity. You would think the opposite would occur. So those 3 groups of symptoms are listed here, and you can see how patients with insulinoma syndromes can present to a variety of different specialists, endocrinologists, neurologists, cardiologists, because of the neuroglycopenia, the lack of glucose to tissues that depend on it for energy. So patients will present with confusion and amnesia and visual changes, even convulsions and altered consciousness. As a consequence of the low sugar, the body tries to restore that glucose level, much like occurs with excess insulin. Many people have heard of insulin shock in diabetics who may be overdosed. And that leads to this jittery syndrome of excessive sympathetic overdrive with weakness, sweating, tremors, palpitations, and a need to eat. As I also have already mentioned, obesity does occur quite commonly. Now, in any neuroendocrine syndrome, you have to have an inappropriate excess of a normal product. So everybody needs insulin, but if you have too much insulin that doesn't go away and causes symptoms, you have inappropriate hyperinsulinism. And inappropriate hyperinsulinism is listed in this table with 4 important causes along the left side, and the tests that can be done to look for that along the top of each of the columns. You may not only have an insulinoma if you have inappropriate hyperinsulinism, and there are other causes. The distinguishing features are listed in blue. So the exogenous insulin, too much insulin, you can look for C-peptide levels or the percent of proinsulin to see that it's endogenous versus exogenous. Endogenous meaning within the body and a pancreatic primary problem. There are some antibody syndromes to insulin that, if positive, can also give you an excessive production of insulin and hypoglycemia. And then there are other drugs that can do this besides insulin itself, and sulfonylureas are the specifically important ones, and you can measure the blood level of these drugs. So there is a differential diagnosis that one needs to think of with any inappropriate excess hormone production, and I'm using insulinoma as an example to show that to you. Let's move on to Zollinger-Ellison syndrome. Zollinger-Ellison syndrome was the 3rd neuroendocrine tumor presented. It's about as common as the insulinoma syndrome, and this was called the non-beta islet cell tumor because it was known to arise in the islets, and it produced excess gastrin, but was from a different cell type. As a consequence of that excess gastrin, patients get gastric acid hypersecretion, too much acid, and fulminant peptic ulcer disease. As opposed to insulinomas, Zollinger-Ellison syndromes traditionally are felt to be low-grade malignancies. And like insulinomas, there are 2 main types. About 2/3 of them are solitary or sporadic tumors. Sometimes you see multiple tumors, as in multiple endocrine neoplasia, and that accounts for about 1/3 of cases. One other difference between Zollinger-Ellison syndrome and insulinoma syndrome is that 90% of the gastrinomas, or Zollinger-Ellison producing tumors, occur in the gastrinoma triangle, which is outlined in an anatomical diagram to the right. So they're often in the pancreas, in the head of the pancreas, not anywhere else in the pancreas, but they also are very commonly found in the duodenum. What's the pathophysiology of this condition? Gastrin is a normal product, as are the other hormones we've talked about. And if you look at the top of the middle of the slide where there is a parietal cell diagrammed, gastrin binds to those cells, gets the parietal cell to produce acid. The acid lowers the pH of the stomach, allowing to begin the process of digestion, which switches on D cells to release somatostatin. That's called a feedback loop, a positive inhibition of the release of acid, so that we don't all make a lot of acid all the time and end up getting ulcers. However, as you can see on the right side of the screen, if in the pancreas or the duodenum there are gastrinoma cells that make gastrin that get into the bloodstream, come to the parietal cells, tell them to make a lot of acid, the feedback loop is blocked and you get inappropriate persistent release of gastrin causing symptoms. Now, those are the 3 most common functional syndromes. Let's now quickly touch on some of the others. Glucagonoma syndrome is very rare. I'm only mentioning this to you because of migratory necrolytic erythema, which you can see on this slide. This is a rash. So these are patients that would present often to dermatologists, and if the dermatologist isn't aware of that, they may miss out on the glucagonoma syndrome. And the vipoma syndrome is another syndrome that presents to gastroenterologists with an excessive amount of vasoactive intestinal polypeptide that causes severe diarrhea, so-called pancreatic cholera, a profound, overwhelming secretory diarrhea. How to medically manage these symptoms? Well, as you can see over here on this slide, the carcinoid syndrome is classically managed with somatostatin analogs, SSAs. The insulinoma Cholesteatoma, glucagonoma, and vipoma also all tend to respond to SSAs. But under the insulinoma, I want to just mention that everolimus has a potential use because it helps glucose control. Under gastronoma, I want to mention that proton pump inhibitors are actually used ahead of somatostatin analogs because they block the final common pathway of gastrin production with less potential side effects. And finally, going back up to the top of the slide again, the carcinoid syndrome, if it is incompletely managed with somatostatin analogs, we can use telotrestat ethyl, which I'll show you in the next few slides. So everybody knows what somatostatin analogs look like and where they bind because they are used both for tumor control and hormonal control. Human somatostatin on the top right of the slide has a short half-life, but octreotide and lanreotide, diagrammed below, have been now released and used for symptom and tumor control in many patients. And here is an example of one of the older slides looking at the levels that are achieved with depot octreotide that shows higher doses get higher levels and better inhibition, although traditionally speaking, because we use these drugs for tumor control as well, people tend to use the maximally effective dose. And there are many studies, if you look at this example listed over here, in which patients have been treated for carcinoid, endocrine tumors, insulinoma, glucagonoma, VRPoma, etc. And as you can look on the right side of the slide, the symptom response is often very, very good, and the biochemical response matches that symptom response. So lowering the hormone in the blood fixes the tumor syndrome. As a consequence, somatostatin analogs are approved for certain functional NETs, but not for all because they're difficult to study. So octreotide is FDA approved for carcinoid, vipoma, acromegaly, lanreotide for carcinoid and acromegaly. They are all, as I've already suggested, useful for any productive neuroendocrine tumor, and specifically are second-line considerations in gastronoma because PPIs are better, and insulinoma because often they don't respond as well unless they're malignant, and the benign tumors, you need to go and find it and remove it. The role, of course, in tumor stabilization has already been well established, is beyond the discussion of today. Let's just end off now with some other specifics. Telotrestat ethyl, which was formerly called telotrestat etoprate, is a tryptophan hydroxylase inhibitor. In other words, it inhibits the rate-limiting step in the production of serotonin, the conversion of tryptophan, as you can see inside the neuroendocrine tumor cells. If you lower the production of serotonin, you will get lower levels of 5-HIAA measurable, and you should, in theory, get lower side effects related to the hormone syndrome. And this drug is approved, as you can see on the next slide, because it did reduce bowel actions in both a lower and higher dose in patients who were stable on a somatostatin analog, but still were syndromic. And this drug is to be used in conjunction with SSAs in patients who are stable. I've already mentioned that managing the acid hypersecretion in Zollinger-Ellison syndrome is easily done with proton pump inhibitors. Symptoms are not sufficient, and so patients need to be overtreated with these drugs, and it requires high-dose, twice-daily proton pump inhibitor therapy. At the bottom of the slide, I've mentioned medic alert bracelets, essential for anybody with Zollinger-Ellison syndrome to have a medic alert bracelet to warn people if they are indisposed for any other reason. They cannot stop their drug because breakthrough can occur rapidly and can actually be quite life-threatening. Here is a study from many years back that we did showing that proton pump inhibitors at once or twice daily at high doses always will control Zollinger-Ellison syndrome, and that even if you stop the drug, it takes some time for that acid production to recover. And let's just end off with some non-endocrine causes of symptoms in neuroendocrine patients. I've modified the slide for all neuroendocrine tumors, not just carcinoid syndrome. Undertreatment of the hormonal syndrome leads to excessive hormone production, and the management there is to excessively treat. So if you don't give enough somatostatin analog to control the syndrome, you can give more, or in the case of carcinoid syndrome, you could add telotrestat. On the second line over here, one of the most common side effects of somatostatin therapy and or resection of the pancreas is steatorrhea, because you lose the enzymes in the pancreas that would normally be important in digesting fat, and you could treat that by adding back pancreatic enzymes. The third line talks about bile salt diarrhea, commonly seen in patients with neuroendocrine tumors, either because they've lost their gallbladder reservoir and they don't have good timing of bile production with meals, or in the case of carcinoid syndrome, where patients have had the terminal ileum resected, where bile is reabsorbed. The result is that too much bile ends up in the colon and gives you diarrhea, which can be managed with cholestyramine and bile blocking agents. Bacterial overgrowth is a consequence of poor motility in the bowel, either from surgery, somatostatin analogs, which cause an ileus, or from the NET syndromes themselves. And as a consequence, you get bacterial overgrowth, and they like any ingested products you give them. And the way to treat that is intermittent courses of antibiotics. I don't think patients should be on maintenance antibiotics, even if they tend to respond. And then there are other causes that need to be considered. For example, the carcinoid syndrome does occasionally present with a deficiency of niacin and pellagra, which can cause diarrhea. Diabetes, as I'm sure you all know, is a very common problem related to any neuroendocrine tumor patients from syndrome, surgery, or treatments, and that needs treatment. Diabetic diarrhea is a well-recognized issue. And then anybody can get diarrhea, whether they have a neuroendocrine tumor or not. And one needs to think about other causes of chronic diarrhea. We've touched on irritable bowel syndrome and inflammatory bowel disease as well. Let me also mention celiac disease, which is a bit of a sleeper diagnosis seen in about 1% of all Americans. And that is something to consider. That is a gluten sensitivity. So in conclusion, and thank you very much for your attention today, let me just end off some pearls that I would like you to remember. Neuroendocrine tumor management requires attention to the syndromic symptoms in addition to the tumor growth. Somatostatin analogs are the initial drugs of choice for syndrome management and for tumor control, probably not in Zollinger-Ellison syndrome, but can be used in that setting too. Telotrestat ethyl is a useful drug for symptom control in refractory carcinoid syndrome patients who are already on an SSA and have stable tumor. It is not useful in syndromes that don't produce serotonin. ZE, as I've already just alluded to, is best managed with proton pump inhibitors. Malignant insulinomas, which are rarer than the traditional benign insulinomas, may be very difficult to manage medically, and in those patients, surgery, PRRT, and or liver-directed therapy may actually be necessary to control the syndrome, in addition to controlling tumors. And finally, symptoms are not always syndromic. Remember that the impact of our interventions on quality of life, especially the results of surgery or somatostatin analogs, that can also cause symptoms that need to be managed. And thank you very much for your attention.